Thank you so much, Chantry, and I'm so honored to be again coming back to Echo in front of this illustrious crowd. And thank you, Dr. Doyle, for everything you do for West Virginia and handling the Echo project for many, many years. Uh, as Dan was telling me, that in your past life, many of you have actually worked in a hospital setting as a respiratory therapist. So, what I wanted to do was introduce you to this new clinical practice guidelines, which has just been published a few months ago. And what is the reasoning, rationale behind it, and how it is going to be clinically important for care of our patients, especially in West Virginia. I have no relevant conflicts of interest to disclose. And what we are planning to do today is to explain what hospital sleep medicine is all about, why we are worried about it, why was a committee formed about it, and why did they come up with the guidelines. And we want to know how to identify these patients who are at risk for sleep apnea. And then, more importantly, implement evidence-based approaches to inpatient OSA and care transition, which is basically what kind of care models can we envision in being compliant with these practice guidelines. So for those who want to be reading this in details, this is the guidelines paper and the citation at the bottom. If you can't get it online, then I feel free to email me and I can share a copy with you. So let's start with a little case here, which I think is very common, will resonate with most of you. 62-year-old male has a heart failure with low ejection fraction, admitted to the hospital for nth time for congestive heart failure exacerbation, treated with IV diuresis, his oxygen and beta blockers and non-invasive ventilation. Initially, the beta blockers were held and then were started later in the course when patients started getting better. So it was noted that this was his third admission this year. Patient was compliant with his medications. His BMI appears normal at 28. His effort score is not necessarily alarming and seems to be within normal limit. And he's unsure whether he sleeps at night because he lives alone. He does wake up several times at night to urinate, but that he implicates to the diuretics. So the question comes to us is this patient's recurring admissions related to something other than an already failing heart? Can undetected sleep apnea be a risk factor for these readmissions? And if it is, then how do I screen? How do I find about the sleep apnea? And if I detect OSA, what can I do in the hospital? And then what do I do at the time of discharge? So sleep disorder breathing, as you know, is a major health crisis costing billions. This is a paper published, about 5 to 6 years ago, where they had pointed out that 80% of sleep disorder breathing remains undetected and untreated, and the cost of that undetected sleep apnea ranges all the way to $150 billion every year in terms of lost productivity, motor vehicle accidents, workplace accidents, and comorbid conditions and diseases. So why is this important in a hospitalized patients? Well, a couple of things. These patients with sleep disorder breathing, as we know, already have significant comorbid conditions, arrhythmias, hypertension, CHF, COPD, and whatnot. And when they get admitted to the hospital, they're even more vulnerable, and this sets them up for a perfect storm. If you look at the statistics of hospital admission, we have 35 million annual admissions, out of which 5 to 6 million are purely because of cardiovascular reasons, and the rest may have significant cardiovascular disease. So there's some eye-opening studies been going on for a decade, all of which have shown that there is upward of 70% to sometimes even 90% prevalence of undetected sleep disorder breathing in hospitalized patients. You might say that pretty much everybody who's admitted to the hospital has a very high risk of having an undetected sleep disorder breathing or a known sleep disorder breathing from before. So the problem is very, very high. But why are we very interested about it? So I wanted to introduce you to a little bit of a physiological basis for this concern. And I wanted to introduce you to something called the dive reflex. And a dive reflex is a physiological response anytime a mammal is submerged in water. And why is that important? Because there are a couple of things which happen when you have a dive reflex and an animal or mammal is submerged in the water, is that there's a tremendous bradycardia. Your heart rate goes down tremendously. On top of that, you're holding your breath, so your oxygen goes down and your carbon dioxide shoots up. And as soon as the animal comes out of the water, there's a sympathetic surge, which makes the blood pressure go up and the heart rate, as you can see, rebounds and becomes tachycardia. So every time this happens back and forth, there is a sympathetic versus a parasympathetic discourse which is happening. And this leads to what we call as an autonomic instability. And why is this animal reflex so important? Why? Because humans also have dive reflex, but it is not as developed as some of these sea mammals. And why is it even more important for us is because the only condition, medical condition, that mimics this physiological response is sleep apnea. How does it happen? Because every time the patient goes apneic and stops breathing, it produces the same physiological response as if you were submerged under the water. You get severe bradycardia as soon as your oxygen goes down, CO2 goes up. As soon as your apnea is relieved, it's like as if you're going over the surface above the water, and then it results in hypertension, blood pressure shooting up, tachycardia, and whatnot, and that's a big, huge sympathetic assault on the system. In fact, this reflex is also elicited in a torture technique called waterboarding. Some of you may be aware of waterboarding, and this is what happens in waterboarding. So many patients in waterboarding don't die of drowning, that water gets into the lung. They die because of the sudden fluctuations in autonomic and get the cardiac arrest. So I want you to remember this dive reflex and how that's important as we go forward. So first of all, we wanted to know if it is such a big problem in a hospital and 70 to 80% of the patients admitted to medicine services actually have undetected sleep disorder breathing. Are we even registering it? Are we even detecting it? Many of our colleagues, when we did this experiment about over a decade ago, felt that they were well versed of this disease. They always, during the consult, educated the patient, made them aware. So we said, okay, let's do a study where, as standard of care, whatever you're doing, we'll see how many of these patients actually came and got a proper diagnostic sleep study within 4 to 6 weeks of discharge. And then the first column, as you can see, is that column, which is about a year of trial with the standard of care where physicians believing that they're doing the right thing, how many of them actually showed up. You can see pretty much next to zero. When we had a structured program engaged after that, where a proper sleep team, screening of that process, education of that patient, and then having a scheduled PSG visit at the time of discharge, there was a 149-fold increase in the detection of sleep disorder breathing. And as you can see, after 4 weeks period of time, 87% of these patients had sleep disorder breathing. So very high yield. Whatever was detected in the hospital was replicated in the PSG. and majority of these patients had moderate to severe disease. So we knew that having a structured program is better than just awareness of this sleep disorder breathing in hospitalized patients. All right, so you may think that, okay, fine, it's good to screen these patients and maybe make them aware, have a planned discharge to a sleep disorder center so that the disease may be captured. But what about while they are in a hospital setting? Is there any downside of having an undetected sleep apnea while you're admitted for these conditions? So what we remember the diaphragm, we said that there's significant autonomic dysfunction and instability in these patients. Well, it so happens that these patients who already have cardiovascular disease at home, when they get admitted to the hospital, they're in an unstable condition already. That's why they're admitted for acute exacerbation. And I think that this lends them to even being more prone to this autonomic instability. And we hypothesized that if they have so much autonomic instability, it should show up some way in a hospitalized patient. And the outcome measure we used was a rapid response. And rapid response is defined in a hospital of something bad happening in the middle of the night or during their hospital stay, which requires a team to assess this patient or escalation of care to ICU, step up, step down unit, and so on and so forth. And we found out that the patients who had underlying sleep disorder breathing had almost double the number of events of rapid response events in a hospital compared to those who did not have sleep disorder breathing, thus suggesting that they are more prone to having bad outcomes in the hospital. Now, with the second part of the study was, what if we knew about this disease beforehand and we intervened by giving them a PAP therapy during their stay in the hospital preemptively? We found out that that significantly reduced the amount of rapid response events during the hospital. So patient safety is enhanced. Escalation of care within the hospital is reduced, and possibly also causing reduced length of stay since patients not having an RT. So that was one of the things which we found out. This is an interesting study, a randomized two-center trial, which we looked at very advanced heart failure, and we defined that pulmonary artery pressure being extremely high. Even to qualify for this study, you had to have a pulmonary artery systolic pressure of 15 millimeter mercury or above, which is considered moderate to severe. And how we dichotomized and randomized these patients was the usual cardiology-driven care for acute exacerbation of heart failure. And these are patients admitted to proper heart failure floor, and we did not interfere in the usual care. But the patients who were randomized to the PAP trial, in addition to whatever the cardiologists were treating, got added PAP therapy if they were found to have underlying sleep disorder breathing. And we found out that within 48 hours, there was improvement in ejection fraction by about 5%, which was significant. And there was significant reduction in pulmonary artery systolic pressure, mean of 15 millimeter reduction. So this suggests that there is a much faster hemodynamic response to treatment of heart failure in hospitalized patients if you have underlying sleep disorder breathing, and that's treated concomitantly along with the heart failure. And that's, again, suggesting that we may be able to reduce the length of stay and hasten their improvement with this introduction. Now, what about admissions? You're all aware that CMS has penalties now for readmission to the hospital for both CHF and COPD. So this is a study performed again a decade ago, where we looked at patients who were recurrently getting admitted for either heart failure and COPD. And we took that index case. A patient had diagnosis of sleep disorder breathing, and we treated these patients and then sent them home on the treatment. And we found out significant reduction in both hospital admission and ER visits in both congestive heart failure and COPD, that's helping these patients prevent recurrently being admitted to the hospital. This is a observational trial where we took our program and we looked at all the 5,000 patients which were screened over 3 years period of time. And you can see the numbers. We not only did high resolution pulse ox and diagnosed them in the hospital, but many of them, 680 of them, had a confirmation gold standard polysomnography post-discharge. And then we followed them for 3 years. And we looked at it, those patients who were compliant with sleep disorder breathing diagnosed in the hospital versus non-compliant. You can start seeing that the curve starts dichotomizing, and the patients who were diagnosed in the hospital and compliant on their therapy had a survival advantage over the next 3 years period of time. This is an interesting study, similar concept, but adding a little bit of a nuance to the study. So we looked at the COPD patients and we looked at 30-day readmissions. And on your graph on my left-hand side, you can see that 30-day readmission is almost double in patients with COPD who also had underlying and undetected sleep disorder breathing. But that wasn't the surprising part, because that had been shown in the past too. What was surprising was that this was a dose-response relationship, which means the more severe the sleep apnea you had, hiding behind COPD, the more the readmission rate and more the death in the next subsequent few months. So this was very helpful for resource utilization and smart triaging. Hospitals are not some places where you can screen every patient inadvertently and start treating them for OSA. So you have to be mindful of the resources. So this study showed us that if we not just screen these patients as yay or nay, but if we actually put a value to the severity, which is the apnea-hypopnea index or the oxygen desaturation index, which are used kind of sometimes as a league for ODI is more beneficial in a hospital setting and AHI more in an outpatient, but they're quite similar. If you use that you can actually go out for the worst of the worst cases and prioritize their treatment as opposed to the milder versions of the disease. So some of you who may be not familiar with the hospital sleep medicine development, this was not an overnight concept. Way back in 2010, we started noticing that patients with heart failure who were coming and getting repeatedly admitted to the hospital had higher burden of sleep disorder breathing. And we often wondered if treating that would make sense. And a first formal hospital sleep medicine program was established by us at Thomas Jefferson University in Philadelphia, where all these studies, which I've alluded to you earlier, these were the foundational work to determine if there's a relationship, association, and an outcome benefit were done. The second phase was an inner city hospital, and we wanted to show whether the same concepts were valid in an extremely resource-dried environment. And this was very important for us too, because this helps us to develop programs for West Virginia, where because of the rurality, because of the inability to access care, they almost behave like inner city hospital. And then the latter part of our testing and investigations were in West Virginia University. And happy to say that our care model program, which is now nationally renowned and available on CHEST, was actually developed here in West Virginia. And then you can see the CPC guidelines, which have just recently come up. This is the group of task force, which ASM put together and commissioned back in 2020 to develop these guidelines. Developing these guidelines was not easy. This task force was commissioned in 2020, and it took us almost 4 to 5 years for detailed synthesis and literature review. It was only in March of 2025 that these were released for public comments. After we reconciled with the public comments, we had this peer-reviewed. After the peer-reviewed, it goes back to the GAP committee. The GAP committee again reviews that, and eventually GAP committee approved it in August of 2025, and these were published in December in JCSM. So a little insight as to how we went around making these guidelines before we go to the actual guidelines. So we used what is known as a very popular model called the PICO model, where you take the right population, you take the intervention which you are going to do, and then you take all the comparison group with that, and then outcome, O is for outcome. And we framed 7 questions which we thought were worthwhile answering. These 7 questions were framed one by patient advocacy groups, which gave us the idea as to what is important to them in a hospital situation. And the rest of the groups or questions were framed by the experts on this committee. We decided that only randomized controlled trials would be used for the main recommendations, although there was much more observational data at our disposal. We decided not to go for p-values. One of the problems with the p-values is it's, it is less understood, and it is widely used, but it may be statistically positive but clinically not relevant. So there's a dichotomy between p-value and really what you get out of it. We wanted to make this meaningful for every hospital out there and not just for academics. So what we used was a clinical meaningful threshold. To understand clinical meaningful threshold, let me take your attention to some of the studies which you may have read. And many of these guidelines are now based on clinical meaningful threshold, which basically means that if I were to intervene or if I were to screen, how many of those people I have to screen to save one life? Or how many of them I have to screen to prevent a complication? And that gives a much better gauge to physicians on ground that what is the burden that I'm carrying? How much is too much? And that, I think, is much more beneficial than the p-values. The other thing we were very cognizant was the limited resource availability in all hospitals, and we wanted to ensure that we are not putting too much burden on any given healthcare system. And then emphasis was on transition of care, because this entire model of hospital sleep medicine will come crashing down if we can't make a transition of care and make sure that these patients are cared for the disease after their discharge, and they are not lost to follow-up. So having said that, the first thing we looked at was, do we save lives? And based on the prior studies, based on TIMI trials and large cardiovascular trials, they have alluded that if we screened 1,000 patients and we saved 10 lives, it is worth doing it. So we take that same benchmark and we applied to our clinical guidelines and said, let's look at all the randomized controlled trial, look at the data, and see how many lives per 1,000 we are. And these are the 4 trials, the randomized control, which were available. And at the bottom, you can see the forest plot that you can see. And at the end, we found out that 14 lives were saved if we screened 1,000 patients in a hospital setting. So it crossed the threshold of 10 for meaningful intervention. Now, there are much more larger and bigger controlled and observational trials. So while the recommendations were based on that, we were just curious to know, what does that data suggest? So we did the same mortality analysis on all these large cohort studies, and we found out that it's 68 lives were saved per thousand. So if you're very, very rigid and want to go with randomized, you go down to 14 lives saved. And if you are taking into consideration some of these observational trials, it can go up to 68. My own gut feeling is the truth is always somewhere in between. So we still are in the positive in saving lives. So how does it compare to other things? I mean, we have these screening programs all over the place, and people ask me, okay, these numbers look okay, but how does it, compare with others? I'm sure that this group was completely aware of the low-dose CT screening for lung cancer, big in West Virginia, CMS approved, and it takes 3,000 screens to save 14 lives. Okay. Compared to the sleep disorder breathing program, which the data we said, which says 1,000 screens required to save 14 lives. So it kind of gives you a little bit of a perspective as to the utility of the program, not to mention that it is much more costlier to start a low-dose CT screening program as compared to the sleep disorder breathing screening program. Now we asked the second question was, what happens with cardiovascular events, bad things happening? So not mortality, but congestive heart failure, myocardial infarction, TIA, all of those bad events that can happen as a complication of OSA. And we again looked at randomized controlled trial. We kept the thresholds the same as 10 complications being prevented for every 1,000 screen as a bottom line. If the data suggests it's less than 10, that was not useful. And you can see again the forest plot curve at the bottom suggesting favorable outcome. And we found that there was 67 fewer cardiovascular events and complications in patients who were screened for sleep disorder breathing in a hospitalized setting and initiated on therapy. So recommendation one on this paper was that for medically hospitalized adults at increased risk for sleep disorder breathing, ASM suggests in-hospital screening of OSA as part of the evaluation and management. Again, we considered that as conditional recommendations since this is a first guideline, and we had put our evaluation mostly on randomized controlled trial, and there were only 4 randomized controlled trial. So we thought this would be a conditional recommendation. The second recommendation was that for patients who are hospitalized, ASM suggests use of inpatient treatment with positive airway pressure therapy. This again goes on to reiterate that this is not just about screening, catching them early, and having them treated at home. You are benefiting these patients while they're in the hospital, whether that is by preventing bad things happening to them, like a respiratory event or cardiac event, preventing escalation of care, which increases length of stay, and patient safety. Third recommendation was that patient hospitalized, ASM suggests that sleep medicine consultation be available as part of the evaluation and management pathway. Here at Ruby, we have a respiratory department which collaborates with us, and they are the ones who screen, and there's a sleep team which is available for consultation. We obviously are very well aware of limited resources of sleep medicine physicians in rural and inner city hospitals throughout the United States. So we have suggested in this same recommendation that it's not necessary to have an in-person consultation. They can have a telemedicine consultation with sleep medicine practice associated with their hospital. The fourth recommendation was the ASM suggests that discharge management plan to ensure timely diagnosis. And again, coming back full circle, that we don't want a situation where we are discovering all of this disease burden in a hospital, and then nothing is done as an outpatient. And that would be a failure of significant resource allotment by the hospital if we are not able to carry these on as an outpatient. So we suggest that at the time of the discharge, the patient be plugged in with the nearest sleep disorder breathing center, have an actual appointment before discharge with a sleep disorder team, whether it's a ASM accredited sleep center is what we suggest. But if any sleep specialist is available in your community or any sleep disorder center lab is available as a resource. The fifth one was very interesting, was not a recommendation, but it was a good practice statement. So what is a good practice statement? Good practice statement is that I don't need to conduct a randomized control trial to just tell you that this is the right thing to do for the patient. So this comes as a part of the common sense, as a common obligation of every physician to do. For example, if you admit a patient in a hospital and you discover and find out that the patient is hypertensive, he is admitted for cellulitis, but he takes 2 pills for blood pressure at home, there is no scenario under the sun where you're going to say, I'm not going to give you your blood pressure medication. That would be considered dereliction of duty unless you had some really good idea or reason for stopping the blood pressure medication. However, that does not happen in the world of OSA. In a study conducted, we found only 6% of the patients who are even formally diagnosed using CPAP at home receive any therapy whatsoever in a hospitalized setting. So these are not talking about that 80% population is undetected. Here we are talking people with an actual prescription for a CPAP at home, actual objective sleep study already conducted, and a formal diagnosis of OSA coming to the hospital and being completely ignored. And the ASM suggests that we don't need a study. This should be a good practice statement. So moving on, how do we translate this into a meaningful service care pathway that encompasses all of these recommendation and also has all the outcome benefits we talked about? So this is the Hospital Sleep Medicine published in CHEST. Dr. Stansbury is the co-author on this manuscript, I think, and he's with us. So, Rob, if you want to add anything, please do so. So this model was designed here at WVU. And one of the issues with this model, which we're trying to get a better sense of, is this is designed for academic hospitals. So obviously you see a whole layer of very detailed practices. So there are several multidisciplinary key programs and key players involved. There's administrative champions, there's departments collaborating, including sleep physicians, APPs, IT is involved with this project. Respiratory department, as I said, are the ones predominantly doing the screening. We have nursing partnership to do sleep studies during the night. And of course, discharge planners are part of the integral part of that process. We have a lot of departmental support. Some of the people who refer to us on a routine basis are hospitalists, cardiologists, neurologists. And then, of course, we had several committees clear this project for us when we initiated that. So based on the CHEST study where I had alluded to you that is not good enough to just say yay or nay. We need to go further into the details and fine-tune whether it's severe sleep disorder breathing or mild, because that can help us triage. We have a two-tier screening process. The first thing is a patient comes in, IT prepares a list every night, how many new patients are admitted to the hospital, and what is their stop bang questionnaire and the BMI of more than 30. We think these are really high-risk things which can be tagged off easily on an EMR. That list is generated, and our respiratory therapist then goes in and performs a stop bag questionnaire. And if they find this to be high risk, these patients are then enrolled into a high resolution pulse oximetry or a home sleep study overnight. The primary admitting team is engaged at that point, and we recommend that these patients be evaluated. And most of the time, the primary care service will put in a sleep consult unless they feel strongly otherwise. For example, they already know he's got sleep disorder breathing, and we had missed that in the screening process, and they already put him on appropriate treatment. There are some contraindication to do a sleep study within the hospital context, whether it's HRPO or a home sleep study. One is if their oxygen requirement is very high, then you can miss all the subtleties of oxygen drops, and that can give you a falsely negative sleep study. If the patient is unable to sleep, whether it's severe pain or patient is having significant wheezing, is unable to breathe, getting nebulizer treatment every 2 hours, every 1 hour, has altered mental status or encephalopathy. All of these will make these studies redundant. So what we do basically is we actually go through this list, and if the patient is still unstable, requiring too much high oxygen, we know his night is going to be extremely disruptive. We wait till 24 to 48 hours for that acute process to stabilize the oxygen demand and FiO2 needs coming down to 3 liters or less before doing the study in the hospital. So what do we do after the study? After the study is performed, sleep-boarded physician reviews the HRPO, and we dichotomize them into 3 buckets. One, of course, is moderate to severe sleep disorder breathing with ODI of more than 15 and oxygen desaturation of more than 20 minutes below 90%. And these are the highest risk factor where something bad can even happen while they're in the hospital. And we immediately trial them on a PAP therapy, most likely an auto CPAP, and then monitor them during the hospital course. The in-between is the mild sleep apnea, the 5 to 15. These are the patients we go and educate, improve their awareness on the sleep disorder breathing, sensitize the primary care teams that if the patient is undergoing any kind of procedure, any kind of sedation, that his risk of having a bad outcome can increase. So ensure that you are aware of that and take necessary action. And of course, ODI less than 5 completely doesn't rule out sleep disorder breathing because there's night-to-night variation, in which case we educate the patient and say that if you do have necessary symptoms as an outpatient, then you should call and contact your local sleep provider. A very similar themed pattern has emerged out of the American sleep medicine. Actually, it is funny because the clinical practice guidelines are near ditto of what we had framed many years ago, and recommend the same type of intervention in these patients. Now, one of the things which we had learned with hospital sleep medicine is that it is a very unique model which not only serves to benefit the patients for their underlying clinical condition, but we also found that was very helpful in reducing healthcare disparities. And I'll tell you how. When we were doing inner city studies, and this is known across the country, many studies done, that the patients who are on the lower end of the socioeconomic ladder are less likely by physician to be asked question on their sleep, get a sleep study. And it probably comes from, from the fact that the physician assume that they may be too poor to afford the therapy or they got much bigger problems to deal with. Whatever the psychology is, it is proven again and again that these patients don't get it. Very similar truth is true for rural health patients because they either don't seek help with a sleep doctor or they're not screened appropriately as well as some more urban setting patients are. So we felt that if you look at this study, that if you applied these standard of care uh, clinical pathway guidelines we have developed, everybody, whether you're lower socioeconomic, higher socioeconomic, African American, non-African American, everybody's getting the same treatment. And lo and behold, it was equal number of representation in our study for patients who were screened either ways. What was very surprising about that unlike our initial thought that these patients may be screened, may be turned positive, but they're not going to avail the treatment, we found that equal number or percentage of these patients actually showed up to the sleep study for sleep study and got diagnosed. So there is a similar kind of implication for West Virginia, where sometimes hospital may be the first contact for healthcare. Many of these patients in the rural area may not believe in outpatient care. They'll probably just get care when they're really sick. So this becomes an important area to catch them and reverse their pathology. This is again in not rural health here, but same reflection of inner city hospital. We followed these patients who were screened, and they found out that they had improved mortality and survival very similar to their higher urban Caucasian counterparts. So the question in this slide, which we tried to answer, was the question which is perpetual, is that if you diagnose patients in a hospital, should you just do a gold standard diagnosis and then send the patient home with the treatment? Or should you just screen them, educate them, and then ask them to come for an actual gold standard in the next 2 to 3 weeks period of time, like many of our studies have done? So this is a large Canadian center which looked at resource utilization and found that the patients who are much more likely to stick to their treatment, whether the CPAP or follow-up appointment, are the ones who get screened in the hospital, but they get a test as an outpatient. Patients who got both screened and diagnosed in the hospital and given the CPAP machine during the hospital stay had much poor compliance with both CPAP as well as outpatient appointment for sleep clinic. So I think the model which we designed seems to be working better, even retrospectively looking at this study. I think there's some utility into looking into those areas. So the value proposition which we give to the hospital is that you have very, very high prevalence. We're talking 78% of your patients having undiagnosed sleep disorder breathing. We have shown very convincingly that there's poor outcome if you don't do anything. So cost of not doing anything is pretty high. And there is a cost-effective way and opportunity to intervene, and that our model has already shown the success of these programs. And this is a local West Virginia real-world study where we looked at not inner city population at some other city, but here in West Virginia. And we showed that there's not only reduced readmission and ED visit, but it actually helps save money, taxpayers' money for both hospital. And then the right side, you see the bars. That's how much the patients who saved in both professional billing, which is basically outpatient expenditure, and DRG billing, which is the hospital billing. So there's both cost savings as well as patient improvement. And here's improvement in throughput. We found that length of stay reduces, which tremendously helps hospitals with throughput and improvement of services provided. So I think that we have now some really good tools at our disposal. One is the real world data showing cost benefit, patient benefit, and now is a American Academy of Sleep Medicine published guidelines for clinical practice that we can really change the face of sleep disorder breathing and how we interact. And from a very, very ambulatory guided specialty, we are thinking that there is a lot more benefit that we can have if we start involving the hospitals with it. So for the hospitals, There's reduced hospital admissions, ED visit, something they care deeply about. We have reduced cost of healthcare, which I just showed you in rural setting. Patient safety is of paramount importance to hospitals, reducing length of stay, improving throughput, and then improving sleep lab utilization. All of these benefit hospitals. Of course, we have some challenges. This care model I discussed with you is much more applicable and replicable in academic centers. So we are in the process of making the model a little bit more less stringent and then something which can be adopted by community hospitals, maybe even critical care hospitals down in rural settings. We obviously have even with the academic center, we have a low post-discharge follow-up rate. We're talking about 30 to 35%. And we are, researching and we found some ways that we can improve that follow-up rate. And of course, as we go forward, we need more randomized controlled trial and continue to improve this model. And I want to take this moment to thank this wonderful team, which has put West Virginia University hospitals on the national platform, where we are sharing our model with a lot of these institutions. This slide set, which I'm presenting, was basically a national presentation in Atlanta a few months ago at the Sleep Medicine Trends. And I'll leave you with this last thought process in this slide. And my only hope is that this is applicable in hospitals where everything comes up from the roof and the ceiling and drops off instead of in a plane. Thank you very much. I'll take any questions at this point.